A 31-year-old female presented with a history of bilateral progressive hearing loss in both the ears of 2 years duration. Her symptom aggravated during her pregnancy. Examination showed normal tympanic membrane. Now, what is the probable diagnosis? The catch that we have to observe is pregnancy, 31-year, progressive hearing loss in both the ears. Coming to the etiology, what do we notice here? Hearing loss initiated or made worse by pregnancy. Hearing loss usually between 20 to 30 years. Females are affected twice as often as males, and it's common in Indians. We have most of the etiology covered here. And symptoms, hearing loss. What are the DDs we have? We have serous otitis media, tymphanosclerosis, adhesive otitis media, and otosclerosis. With the etiology and with the symptoms, we are thinking it's going to be an otosclerosis. Yes, otosclerosis is more aptly called otospongiosis, and it's a primary disease of the bony labyrinth. So what happens here is one or more foci of the irregularly laid spongy bone. The spongy bone replaces the normal enchondral layer of the bony otic capsule. So this is the problem here. The bony otic capsule is replaced by a spongy bone. Now this, is the bony labyrinth with cochlea, with vestibule, with the semicircular canals. So this is your whole bony labyrinth. Moving on to the types, the one and the most common type is stapedial otosclerosis. So this causes conductive deafness, and it's the most common variety. Here the lesion starts just in front of the oval window in an area called fistula antefenestrum, and it is of further types, which is anterior focus, which is the site of predilection, and the lesion may start behind the oval window, which is posterior focus, and around the margin of the stapes foot plate, which is the circumferential, and in the foot plate, but the annular ligament being free, which is the biscuit type, and the last one, it may completely obliterate the oval window niche, and that is obliteration type. So here are your different types. The A is the anterior focus. The B is your posterior focus. And C is circumferential. And this is the biscuit type. And the last one is obliterative type. This is called stapedial otosclerosis, the most common. Moving on to the pathology, grossly otosclerotic lesion appears chalky white, grayish or yellow, sometimes red due to increased vascularity, and microscopically the spongy bone appears normally dense endochondral layer of the optic capsule. In immature active lesions, there are numerous marrow and vascular spaces with plenty of osteoblast, osteoclast, and cement substance, which stains blue mantles with H&E stain. The mature foci shows less vascularity and laying of more bone and fibrillar structure than the cementum, and it is stained red in color. It's stained red. Now, this chalky white appearance is seen only in the mature. But when it is active, you see something called the flamingo sign. You call it flamingo because it appears pink in color. Something which is active is always red. And as you can see, this is not an active one. So not active, because if it is active, it will be red in color. So this is a gross developed one, which is chalky white or yellow. Now coming to the symptoms. The first one is called paracusis will I see, which is an autoclerotic patient hears better in noisy than in quiet environments. This is because a normal person will raise his voice in noisy surroundings. And the second one is hearing loss, where it usually starts in 20s. Next, as commonly you know, tinnitus, which is commonly seen in the cochlear otosclerosis and active lesions. And the last one is vertigo. But vertigo is an uncommon symptom. But all other three is common. So this is paracasis, Willacy, and this is hearing loss, and this is your tinnitus. Moving on to the signs. Tympanic membrane normal, eustachian tube normal, Renner test negative because bone conduction is more compared to air conduction. Weber's test is lateralized to the ear with greater conductive loss, and ABC is normal. So you have normal tympanic membrane, normal eustachian tube, normal ABC, but what you have to focus on is the Rennie's test and the Weber's test. Coming to the treatment, you have medical treatment and surgical treatment. But you have to know and understand and remember that there is no medical treatment. There is no definitive medical treatment. So what do we have to do straight? We are moving to the surgery. And as you know, we are dealing with the stapes. You are going to do stepidotomy or stepidoctomy. You know, tomy is to do a surgery and remove, and stepid is involving the stepides. So it is stepidoctomy or stepidomy with a placement of a prosthesis is the treatment of choice. So you have to remember there is no medical treatment, and the surgical treatment is stepidoctomy. Coming to the summary, the etiology is hearing loss initiated or made worse during the pregnancy, and hearing loss usually starts between 20 and 30, and females are affected more. Coming to the pathology, you have to remember active lesion, flamingo pink, because active is always red and vascularized. Gross lesion is yellow or grayish and chalky white. Moving on to the symptoms, you have hearing loss, paracasis villi, tinnitus, and vertigo. And the last one is signs, where the tympanic membrane normal, eustachian tube normal, ABC normal, but the Rene's and Weber's is what you have to keep in your mind. Coming to the last, there is no medical treatment. Surgical is stepidotomy. Active lesions, as you know, it's rare and active. That's why you have the flamingo pink sign there.